So it's an absolute honor to speak to you guys, and as Carmen was saying, this is not the first time I've been part of this group for a number of years, and this time is special, particularly for this topic. I'm going to talk about TruNatomy, which is a baby of mine, so to speak. And so I have to disclose a conflict of interest. And you understand that I'm one of the two inventors. George Bruder is the other person who is not here today. So what we're going to talk about is a restoratively driven path to endodontic excellence. And I need to give you a couple more elements before you understand what we meant with that type of verbiage. And let's take a look right into the meat of the presentation. One of the things the presenter yesterday told us, know your material and be on time. So I'm trying both of those things. These are examples of endodontic treatments that individuals have done that are associated with my school. Dr. Anna Arias and Payman Barami did these cases just as of the collection of cases that we have. And why I'm showing you this, we all like to see these artful things. We're focusing on the radiographic appearance. That's the look, including the apical dimension, including the curvature, including, if we are so inclined, minor sealer overfills. But that's really only one element of endodontic treatment, as we all know. So we got to think it through a little bit. And one of the ways of doing that is to look at success and failure. We have done this 100 times. So what can I add to that discussion? Well, bear with me for a minute. We know what is failure, right? In this scenario, of course, the patient comes back after endodontic treatment, and she has developed an abscess. Clearly, there's something not right. Whatever we did, we cannot term that as success. And when we look at the associated radiograph, you can argue, okay, there's apical infection probably at some point associated with the radiographic appearance of apical periodontitis, and that has led to an abscess formation, or maybe that has to do with the thinned out furcation and the infection pathway is through that, or maybe if you feel like this is the reason, maybe has to do with the overfill. It doesn't really matter. The presentation is what it is. What I'm trying to say here is we don't know some of the details, even if we term this a failure. Let's be a little bit more philosophical here. And I owe this discussion to my good friend Thomas Quist in Gothenburg. And he goes about this in a different way. And if you get a chance to read what he writes and to listen to what he says, it's definitely worthwhile. I really enjoy looking at endodontics in a bit of a different way. So his analogy is the Heap Paradoxon. So what is this, right? In Greek philosophy, the paradox of the heap is the following. 1 million grains of sand will form a heap. Of course, that may not be a million that we are seeing here. But if we subtract 1 grain of sand, it's still a heap. And we subtract more grains and yet more grains, it still will be a heap. We have to decide at which point the heap stops to exist. Clearly, 1 grain of sand is not a heap. Likewise, how can we know that apical periodontitis exists, right? How many inflammatory cells do we need? Is there a cutoff point? What does it mean? Does it mean that we have to see something on a periapical film? What does it mean if we expose the patient to a cone beam scan and we see some changes in the periapical ligament width? And he makes this graph here, which Thomas does. And so I think this is something that we have to take home and think very carefully about when we talk to our patients. When we begin on the left, we have the green bars that are pretty tall. And they're indicating that we are very successful if the yardstick is tooth retention. Extraction, the opposite of retention, only very small red bar. If we go to the far right, and the measure is biochemical analysis. If we're able to take routinely markers from the serum or the apical tissue conditions, then we will probably have some degree of inflammatory response every single time. If this were to be our marker, we would never be successful in endodontics. So we can take our pick. Are we going to be in the middle, right? Intraoral radiographs, we're at the proverbial 80-20 breakdown that we have learned from Shimon Friedman and many others. If we go to cone beam analysis, we are at a 50-50 breakdown. I think we have to think this through very carefully to make a good recommendation for our patients on an individual basis. But in principle, this type of analysis opens the door for another question. The goal of endodontic treatment is defined in many textbooks as treating or preventing apical periodontitis. And this is a worthy and important goal. But in the end of the day, it's a sub-element of the goal of endodontic treatment as I would like it to be defined, which is that endodontic treatment serves to support overall restorative therapy, serves the goal of long-term, if not lifelong, retention of a root canal-treated tooth. If that's the case, we can consider other things. And Thomas is in the process of developing an endodontic health index. Right? The goal should be bigger than looking at the radiograph and telling the patient the black area has shrunk from last visit, right? Not belittling that in any way, shape, or form. This is important, but it's only one goal of the things we are talking about. If we are talking about oral health in general, we have to be able to measure and be a little bit more objective about what we're doing here. We'll talk about this maybe to a longer extent another time, but I need to refocus on the task at hand, which is TruNatomy. So when we take a look at that, I want to present every time I do this something that not everybody has read and not everybody has seen 100% of the time. This is a phenomenal paper that I use a lot because in long-term outcomes, we have to be a little bit more circumspect than going into endodontic literature. Liran Levin is a periodontist who works now in Canada, and this was written when he was still in Israel. An excellent paper, tooth preservation or implant placement, right? This is a review of a number of very long-term individual studies. Excellent, excellent work. So the studies typically included have more than 15 years follow-up. I'm tired of one-year follow-up studies with 20 patients. Right? And they're looking at the 19 papers here, and the breakdown is tooth loss is between 3.4 to 13% in those studies, and implant loss between 0 and 33%. I am not an implant hater. You know, I'm a restorative dentist, as well I tell you in a bit in my past. So an implant is an important tool. But the chance for an implant to perform better than a tooth is not a given. No meta-analysis, I think we all know this, there's two diverse data sources. But in the end of the day, the conclusion matches with what the current thought process, I think, leads us to understand that implant survival does not exceed that of teeth. It may be worthwhile, these are his wordings, to retain even a compromised tooth for as long as possible. And I'm wording this very carefully. Not as long as feasible, not as long as desirable, but as long as possible. That's a pretty aggressive thought, and I don't know if this is mainstream. But tooth preservation, retaining teeth for the long term, is the goal of what we're doing, which is the essence of restorative thinking, the way I'm looking at it. So where are we? Where do I come from? Let me show you a very simple case example. This is a patient that I treated many years ago, and I was in charge of the upper left second premolar, and I finished that tooth, and I'm looking at the mouth and checking out everything in general and say, okay, there is something here that you got to take a look of. And that's a sinus tract, obviously. And I treated this tooth in the standard way I was doing it at that time with rotary instrumentation, calcium hydroxide dressing for 2 weeks. Details don't matter. Sinus tract heals predictably. This is the radiographic appearance. Nothing abnormal or stellar about it, except for one finding. The distal buccal root has the chronic periapical abscess associated with it. And why is that? Because there's an uncleansable situation with the splinted to abutment teeth of a cantilever bridge, right? And so I could patch this, but I had to tell the restorative dentist, you have to change the restoration, and he did, and now we have a regular prosthesis, and the caries defect at the margin is cleaned up, and this is a 4-year follow-up to indicate long-term success. Only in conjunction of those two things can we do this. When I talk about restorative thinking, you know, in one of my previous lives, I was a restorative dentist. As I mentioned, I was doing those kinds of things, right? This is a 75-year-old patient, and she is at the end of her dental career. And we did this combined prosthesis. I did a lot of root canal treatments. I did a lot of posts and a lot of abutments and all kinds of casting and all kinds of stuff. Look, I mean, I'm not doing this anymore, but we did these types of prostheses in Switzerland routinely. Is that something that everybody gets? No. But you know Switzerland, this is a country, for those who are not Swiss, where a patient comes up when I tell him the patient will need, out-of-pocket cost, of course, will need to pay up front 50,000 Swiss francs. And they say, is a check okay, or do you want it in cash? Right? I don't know. That's not my experience in this country. So this is just the framework. But I think the essence is what the data shows. The data shows this every time I'm looking at this. This is probably the best designed study. In Sweden, every individual treatment is entered into a database. So you can track for every patient what the fate of the root canal treatment is going to be, or what the fate of the patient that has a root canal treatment in his mouth is going to be. So they took a random sample out of this clinic, and only 420 teeth out of 10,000 that were looked at were analyzed. But it's pretty representative and very well structured. What they find, and again, this is Thomas Quist's people, they find that the overall survival over 10 years is 81.5%. Out of the 73 extracted lost teeth that didn't survive, 42 were removed for restorative reasons. 5, I repeat, 5 for endodontic pathosis that couldn't be treated any other way. The breakdown may be 20% endodontic reasons, 80% non-endodontic reasons, or 25% endodontic, 75% non-endodontic reasons. The cause for extraction. And every paper that I'm looking at shows the same thing. Endodontic causes are a minority of those that ultimately lead to loss of the tooth that we have root canal treated. We should deal with that 75 or 80%. That's the restoratively driven path. Let's see if we can make endodontic excellence out of that. Just for completeness, what he shows is some reasons that are correlated with the loss of these teeth, and among them is the type of restoration for a number of reasons. So we have to reconsider, and I know this is a discussion that's ongoing, both at the AE level and at the ESE level, what endodontic outcomes really are. Is there a truth, for lack of a better term, in that? Clearly, antimicrobial effectiveness, debridement effect, is not the one sole issue that we should be preoccupied with. The simple calculation is this. There's 100% effectiveness. Bacterial killed to the level that the canal is sterile, which we are not going to reach. Clearly not 101% effectiveness. As long as we are in the unknown of the 95, 96, 97% effectiveness, really reaching this ceiling, and I will tell you a little bit more about it in just a second. To the contrary, the data for dentin preservation and the association that dentin preservation has with fracture resistance is pretty strong in general. The details are tricky. There's no ideal model to test that, and I will tell you also about that in just a couple of seconds. So bear with me for a very brief introduction to basic biomechanics, very briefly. But before we get to that, I want to talk and speak specifically to the elephant in the room, or one of the elephants, which could be, for instance, a multisonic, ultrasonic, or whatever unit that costs more than $10,000. If you think about it on a business scale, we look at the rate of diminishing returns. Tick disinfection efficacy that I'm showing here on the vertical axis. 100%, as I mentioned, we will not reach. That would mean sterility. And where are we? Are we at the $1 to $10 segment, where the rate of diminishing returns is very positive because the maximum return on investment occurs in that game? Using a thinner needle, maybe using some kind of irrigation enhancement that is in the cost spectrum in that range, or maybe even more, is going to give us the maximum return, as opposed to the maximum yield that will only occur when we do things like maybe ultrasonic activation and stuff of that nature. However, if we put all the eggs in one basket and end up on the far right of the scale, we may have to cut corners in some other areas and not yet still get to the level of irrigation efficacy that we want to have. those of you who are trained in microbiology know that disinfection only occurs by a reduction of bacteria by 3 orders of magnitude, 99.9%. We do not reach this level predictably in conventional endodontics. There's just no way around it. So let's talk about structural integrity for just a couple of minutes for us to understand what the philosophy of minimally invasive endodontics is, whatever that may be. You can tell already that I'm not approaching this in the way normally I would approach that, and I have done this for a couple of years just to think outside the box. Just doing the same thing slightly differently is not getting us any further. Philosophically speaking, there's 2 schools of thought. Wittgenstein is well known for his thought process where he said, what you don't know, you shouldn't speak about. But realistically, he talks also about himself, because he felt he was a genius, right? If he knew what the case was, he knew it. Maybe the others didn't. As opposed to his compatriot, Karl Popper, who looked at it very differently. He asked the question, what is it not? And this is essentially the basis of how we do science right now. 95% significance, or 0.05% significance level, only means there's a 5% chance that's completely wrong what we're saying. Right? And this is Popper's argument. I only know what it's not. Right? How does it relate to minimally invasive endodontics? Wittgenstein would say, okay, I know it when I see it. Is this minimally invasive endodontics? This tooth actually had a post and some kind of a root canal treatment, but the mesiobuccal canal here was still vital. That's not minimally invasive endodontics, I think. How about treatment? Okay, doable. But vis-a-vis, Popper would say, I know what minimally invasive endodontics surely is not. Right? Look at the post on the initial treatment. On the left slide, the older radiograph. This crown was lost and re-cemented with an even more reinforcing post on the right side, only to end up like this. Right? So we've got to think this through very carefully. And let me give you a data point that I think we all need to understand. This is a paper that I guess most of us, if not all of us, have seen out of Toronto. Krishan, Anil Kishan, and Shimon and others have looked into these questions for a long time, and there's no universal answer to that. The question is a smaller access cavity, right? Is a smaller access cavity known here or denoted here as constricted or CEC access cavity, is that preferred in terms of fracture resistance? Well, if you believe Krishan's paper, it is. So structural resistance or structural strength is enhanced. And this is particularly true for premolars and molars. This shows us back, years back, that it relates to what Rhea and Messer did in Minnesota in the 80s and 90s. But here's the key. Let's think this through very carefully. They are showing 1650, 1800 newtons to fracture in the Krishan paper. Correlate that to Rhea and Messer. This is in kilograms, not newtons. So 1600 newtons, 160 kilograms. Not too far off, right? 250 is the unaltered tooth. These are premolars, by the way, in the Rhea and Messer study. Gold onlay appears to have reinforced the tooth. Fracture load increases, as opposed to all the other treatments that have drastically decreased the structural strength of the tooth. Well, so far so good. Well, let's be realistic. Let's be realistic. This is 500 kilograms, right? That's a small size car, right? Put this number into reality requires us to understand what is the maximum parafunctional biting force. According to the literature, it's in the range of 800 newtons. Parafunctional maximum force occurring in the posterior mandible. It's 800 newtons, not 8,000, right? So never, in realistic terms, will that amount of force be reached. Never. So all these tests are not telling us the real story. We've got to understand this much better. But for lack of a better test, this is what we have. Right? This is what we have. The behavior, the biomechanical behavior of a tooth is going to be altered, and it's really going to be altered negatively as soon as we intervene, as soon as we drill a hole into the tooth. Is it by 10% for the access cavity and 60% by an MOD cavity that we would like to believe and that we teach our students? Maybe that's too simplistic. But you're a good group. You understand this, I know. There's much more to be said, but I don't want to do this right now for the shortness of time, and I see the dreading seconds that are ticking down here. Let's just add one segment to that. What is really the yardstick that denotes fracture resistance is the area under the stress-strain curve, the purplish segment here. And the area is bigger than the area normally would be if the slope or the elastic modulus is somewhat lower, and then some kind of viscoelastic behavior, this is dentin, by the way, some kind of viscoelastic behavior occurs, as opposed to a tooth that is now restored with the post and the crown and the stiffening that occurs with that. So look at this. This is what we think sometimes, or many of our colleagues think sometimes, of the reinforcement. What you see is the curve is much steeper. The elastic modulus has increased, but the area under the curve, also known as toughness, is drastically decreased. The maximum load to failure in the lab, remember the car that runs over this tooth, the maximum load to fracture may be higher, but the resistance, the ability to resist fracture of this tooth is drastically lower. That's unfortunately sometimes a little bit more complicated, but the easy thing is in the clinic we see things like those that are unfortunate after we tried very hard to retreat this tooth, which was a difficult premolar, or sometimes a patient like this is on the wait list and has a tooth cracked and mesodistally fracture lines occur. So fractures and restorative issues are a reality. There's no doubt about it. We just don't understand them correctly. Does that require some new solutions? I would say yes. Let me talk about this new solution in general terms and then in specific terms. We provide a crown, cuspal coverage, based on literature that is less than strong, right? Aquilino and Kaplan, for instance, talks about crowns with amalgam restorations in a retrospective study design. Retrospective studies mean everything that looks good, okay, you get a crown. This looks crappy, for lack of a better word, you get an amalgam restoration. What's the outcome going to be? Right? Cannot be a good study. So this is a randomized study out of Italy. Marco Ferrari, who's very strong in composite restorations. And the bottom line, I don't want to go into the details, this is a high-level evidence clinical trial, randomized JDR publication and so forth. So it's a good study. And it looked at the effect of different restorations onto the 6-year retention potential of endodontically treated premolars. And the amount of retaining structure is a decisive factor. And it allowed the clinicians, more often than not, to place a direct restoration rather than a composite. Let's let that sink in for a moment. Sometimes, obviously, there's a need for a crown. More often than not, on a premolar, there may be. Sometimes there's a need for a post. But every of these procedures adds destruction to the tooth rather than making it better. How can we do that differently? So maybe we have to look at the objectives of root canal treatments a little bit different. So really, more often than not, the patients come in to either get remedy from pain or make sure that pain doesn't occur. That's the primary reason. Last time the patient asked for a reduction of inflammatory cells, I cannot remember. Preserving the tooth in the long term, clearly that's what we like to do. And of course, apical periodontitis is an issue. Untreated apical periodontitis can lead to abscess and death, and did 100 years ago, and even now, obviously, does occasionally. So, a new solution. What could be a solution is a different thought process. And I really highlighted and I want to reiterate what the thought process is. The thought process is what leads to extraction of root canal treated teeth. Alan Glaskin and my wife and I wrote this paper that is shown very small on the top. And so we were talking about what is it really, what is minimally invasive endodontics, and what we're trying to achieve here is having enough respect for tissue so that we can enhance the long-term outcome for any given tooth. And the simple question that we have to ask ourselves, have we not adjusted the tooth to the shortcomings of the tools up to this point? Is it not better to develop an instrument that can provide just the right service? And I had enough time when I was in Australia to think about this very hard. And my good friend George Bruder and I were looking at what could we learn from TruShape, how can we get better? And this is what I'm going to show you in detail. And I invite you this afternoon, we have a tech lab, and we can certainly play with these things, and you can take your own look, and not everything will fit for everybody. I'm energized about this instrument. I think it's a fantastic tool that does exactly what I would like it to do. Oh, talk about tools. I heard yesterday from a good friend, you should never say tool. It's Black & Decker, it's cheap, you don't want to do that. But sometimes these are what the things are, right? These are, we are still repair mechanics, and I hope that I learned something from the next presenter how we can harness biology. But at this point in time, this is what we do. So we have 5 uniquely designed instruments here that are manufactured very differently from before because we have a smaller wire that requires higher tolerances. We have a specific alloy that is heat treated in a particular way so that we can generate manufacture files that have a 0.8 maximum fluted diameter. Due to the abilities of the instrument to prepare, we can get away with a smaller coronal opening, with a smaller dentin sacrifice. The handle is shorter. As you will notice when you play with this instrument, the handle is only 9.5 millimeters, so you gain almost 2 millimeters in the posterior mandible, which is really a cool thing. Production processes needed to accommodate that, and I'm pretty proud that we would be able to manage that. You will say, okay, how about debridement, right? So the debridement shown in the TruNatomy preparation indication, the debridement is accomplished, of course, apically. And the debridement is not compromised because we have different sizes where we can go to the size that we need. It's coronally where we are conservative. And I'm not meaning ridiculously conservative, right? I'm not asking you to prepare truss accesses or anything of that nature. How do we do this specifically? I'm just giving you a couple of details on the instruments. For instance, the dimensions of the 3 main instruments in the basic set are the following. We have a Orifice modifier that is a very short instrument, cutting efficient, with a size 20 tip. The cross-section is shown here. This is a pretty sturdy, strong instrument, not super flexible. It is not intended to be taken into the curvature. That's why it's so short, right? I want to prevent instruments from being taken deep into the canal. Think the SX. I mean, people sink the SX to the maximum into the canal. That's not good. The second instrument is the glide path instrument that is shown here with an apical size 17. Very efficient. It has a somewhat cutting tip. I wouldn't call it a semi-cutting tip. I would call it a somewhat cutting tip. And it's very efficient. It's, try it. It's a very cool instrument to use. It's a 17 size. The next size is, which surprises many of you, is a size 26, and the 26 jump from 17 to 26 is very easy to manage. This is a cutting efficient instrument, very smooth, goes to length easily. Don't spend too much time thinking of the tapers. These are average tapers. The taper at the tip is bigger, taper at the end is smaller. Average taper, regressive high taper at the tip, very low taper at the shank portion. The prime instrument, the red instrument, is non-cutting, has a guiding tip and a parallelogram, slight parallelogram cross-section. Very smooth. I'll show you some data to support that in just a couple of minutes. This is just a collection of 2 cases. In the center, you see a TruNatomy case and another Dentsply product that produces a more tapered shape. And I'll leave your imagination open to what instrument that is. Same clinician. 2 years apart. This is Arman Ghazi in Brussels, who is an excellent clinician. Also the left, highly curved mesobuccal root with MB1, MB2, also Arman's case. To the right, Elio Beruti in Italy. So these things are out in Europe already. They are not going to be out this day or tomorrow here, but very soon we will sell this instrument in the US. I should say the obturation technique that Elio uses is thermofill. not gutter-core. This is the thermophil carrier on the case on the right, and warm vertical compaction is on the left and in center. The dimension change is obvious. Coronally, shouldn't be obvious in the same tooth, apically. It's not only the 3 instruments, 2 other instruments, and we have these options for very small canals, yellow, larger canals, green. What you see already indicated in this slide is a new irrigation cannula, and I will talk about irrigation in a second, but let's talk about the coronal modification first. It is essential in the way I try to perform endodontic treatment with an instrument like this, which is thin at the tip, with an irrigation needle that is also delicate. For people that find a receptacle, to find a reservoir where they can place the irrigant as they start instrumenting the canal. And obviously, this has to occur before anything is placed deep into the root canal system. This we call Orifice Modification. We should use this Orifice modifier every time, and I don't want to go into too many details here, except for one thing this slide gives me the opportunity. This is a high RPM, low torque instrument, RPM 500 for every TruNatomy file, torque 1.5 Newton centimeters for every of these instruments. The actual usage torque is below 1 Newton centimeter for the most part, in lab conditions anyway. Why is that? Because we want to do a low impact shaping. We don't want to subject the tooth to high strain, and we don't want to subject the instrument to high strain. Efficiency is much higher. It's very smooth, and a very fast shaping is possible. At the same time, endodontics is not a sprint. It's a long distance race. You got to pace yourself slowly. Slowly does it. Okay, I talked about irrigation for a sec, and I will continue that. This is the new irrigation needle. It's a plastic needle that is flexible in all directions and can be placed in a curved canal without binding in the canal efficiently. The endoactivator is a good tool, and you can definitely use it with this. Both the yellow and the red tip will work in prime preparations. There's an example of irrigation. George Bruder did this video. I only captured a still image out of this. The apical extent of a pro-rinse of a 30-gauge needle is about this in the 27 size preparation. And if we use the TruNatomy needle, the plastic needle, this is the irrigation efficiency that we get. The needle should be activated. It has 2 ports, as I will show you in a second. Should be activated. Irrigant should be expressed on the outstroke, and it smoothly goes into the canal. Very nice. I promised you that I show you the video on the outstroke, but on the expression, but I don't have it in this slide set because it's not, the time doesn't permit to do that. Maybe I show it to you in the afternoon under the microscope in the tech lab. But at this point, it's important to think about debridement for a minute. Carmen was so kind to introduce me with reference to the micro-CT images. So the wording, the touched surface idea is something that is close to my heart. I started doing this in the mid-90s, so it's a couple of years ago. And it's an important variable. But you have to look at debridement as the antimicrobial effects in general a little bit more succinct. So we talk about, and many groups have done that, we should talk about the required shaping, we talk about the cross-section, and we use all kinds of methodology. And as I mentioned, the treated surface is another variable in there, and lots of things happen in that scenario. But we also have to consider the amount of residual debris. We noticed this in the early 2000s already in the micro-CT scans, but only Frank Packe wrote this up many years later. Other people have talked about this for a long time, and obviously you see debris. Debris, first and foremost, is hard tissue dentin shavings that we create. A very rational, very simple thought is get the debris out, but also equally rational it is make as little debris as possible, right? So we have to think what happens to this hard tissue debris. It's either captured in anatomical spaces and doesn't go anywhere because we don't get all of it out, or it's pushed out of the apical foramen, both of which is not what we want. And there's a couple of new thoughts that I want to share with you that we developed over the last maybe 4 or 5 years. Harold Messer gave me this slide, and it's quite obvious. You know, anytime you have a isthmus-type formation, and in the magnification of this cross-section, In the magnification, you see very clearly that while there's a large round preparation, this is done with light speed, by the way, a large round preparation, the debris hasn't been able to be removed out of that canal shape. In fact, all what we have created is now a very thin radicular wall. Right? That's not what we want. And this is a great paper. I always use that. Ram Nair did this with Jorge Vera and his group in Mexico. What he really clearly denotes is that the isthmus and anatomical ramifications in all those cases, and I don't want to go into detail for the paper itself. If you're not familiar with that, please read it. We got the award for the 2005 year in OOO. There's bacteria encapsulated in these dentin shavings. Right? While it's in the isthmus at some point in time, it may not matter because they don't get immediate direct access to nutrients and to the PDL. Equally important, if not more important, is debris that's left over in apical conditions, apical ramifications, canal irregularities, and so forth. So we did, I'll take a look at this with a Brazilian guest student, and she could show that the presence of dentin debris reduces antimicrobial efficacy even for sodium hypochlorite. It's easy to understand for cationic detergents like chlorhexidine, but it's not so easy to understand why this is the case for sodium hypochlorite. And in the recent years, Arias Molis in Spain has done some work on that is quite compelling, I think. And we got to look at this a little bit more. So there's 3 avenues why dentin shavings are negative. Among the inability of irrigant to get to the space that dentin shavings now occupy. There's a buffering effect. Of course, dentin is a buffer. There's also an electric charge situation, physical-chemical charge situation, because cationic molecules like to sit on dentin, hence the substantivity of chlorhexidine, right? But it's sequestered out of the solution into large surface areas that are now occupied by these dentin shavings. And finally, I think there's a surface area effect where sodium hypochlorite is depleted by dissolution of organic material in the presence of obviously dentin powder. So dentin debris is a problem. I do have this, great. So that's the irrigation needle, and this is the 2 lateral ports that are directed towards the apex and allow irrigation at a higher level than we had it before. Obturation, big question. We would like for this instrument to be as adaptive, not only to canal anatomy, but also to markets. And obviously, not every market is the same. There are people that like to use lateral compaction. Probably this is not ideal for lateral compaction, but we need to test this out a little bit more. Most people in this room probably prescribe to vertical compaction or other thermoplastic techniques. But in any case, we are committed to offering this after what we have learned from TruShape as a comprehensive solution, including obturation. We work on retreatment. We feel like TruShape is a very good adjunct for retreatment, and that's where the thought process goes towards now. Speaking about obturation, I think we have to come also to grips with some of the discussions here. I'm doing quite a number of medical legal cases at the moment, as does Alan, who I'm sure is in the room here, Alan Glaskin. And more often than not, it used to be sealer overfill in the past, and it's now calcium hydroxide overfill that creates the nerve damage that we don't like. Yet, obturation, filling the canal, is the way we demonstrate proficiency. It's the calling card of an endodontist. You will want to produce the same thing all the time. Every canal is filled to the spot, and if you believe in that philosophy, you want just to have a smidgen of sealer overfill to denote patency, right? There's nothing magical about it. That is why warm techniques, for the most part, are viewed as a sign of competence, right? Yet, this is also what happens, right? This is only minor in the maxillary sinus. This is not what we wanted. Neither is this or that, right? So we have to marry what we want to achieve with the safest way of doing that. And so that's something that is an ongoing discussion that we have to take a good look at. Obturation is part of it, but obturation has to serve the overall purpose. In the last third of my presentation, let me convince you a little bit more that I have done due diligence for this product, and I have. Let's take a look at what data we have. This is maybe another paper that you haven't seen. We were talking about anatomical varieties and the difficulty to predictably even get to patency, right? What is really in a poll, if I were to ask any and all of you, what is most difficult? It may be variable here, but there are certain steps that are defined as most difficult. Maybe making the right diagnosis sometimes, but from an instrumentation purpose, I think the step from finding the canal orifice to achieving patency is probably the most difficult, right? As soon as we have a glide path, everything is smooth sailing. Here, in this particular case in the lab, I had a hard time myself. You look at the distal root of that tooth, I have counted maybe 8 or 9 sizable apical canal portions. Which one will the file get into every single time? And that's not trivial. That is part of why endodontics has been described as working in the dark. This is a strong group. This is also in Gothenburg, Sweden, and they do some surveying, some philosophy questions, and this is an interesting paper. Liz Dahlström says here, high levels of stress and frustration in relation to root canal treatment were reported overwhelmingly by GPs. Root canal treatment was regarded as complex and was often performed with an overall lack of sense of control. It's not good. People are afraid of doing a root canal treatment. Not in this room, of course, right? But overall, out in the wild, they are not happy with what they're doing. They're working in the dark, literally speaking. What does it mean for a new product? It means that the product has to give the clinician confidence, has to be used with perceived smoothness, with ease, with predictability. And some features like the shorter handle and penetration ability of the glider, and the feeling that they have when you instrument with one instrument after the other are designed to give the clinician confidence. How do we know? Okay, we do mechanical testing. The basics is very simple. Fatigue testing, this is a new fatigue fixture that we have that is brand new. And there's a couple of things that we can show definitively. The fatigue resistance of this instrument, and my only testing, of course, the two main finishing instruments here, is enormous. It's at least a factor 20, if not far more, higher than any competitors that we have tested it against. Owed to the fact that the dimension is smaller, where the bend occurs, and also owed to the fact that the alloy is a different alloy, and I will show you that in a second. Then we do other tests, and some of you may know this fatigue set that we have had for many years, published about 25 papers with that machine with different collaborators, if not more. And what we measure with this is, for instance, this. Okay? This is torque during work, during instrumentation. And what we see here is on your left is TruNatomy, on the right is ProTaper Next. And obviously, the bars are of similar height. The black bars is the second pass. The first pass in the program, this is all done automatically. There's no human interaction. The first pass is 2 millimeters short of working length, and the second pass with 1, 2, 3 insertions goes to working length, right? So the second pass, of course, generates higher torque, and obviously you can see the torque increases from the first to the second pass in each case, but it's very similar for the TruNatomy instrumentation, and it's below 0.5 Newton centimeters. Very low, low impact torque, low impact shaping in general. Another test that we can perform here is the threading in force, the propensity of an instrument to drive itself into the canal. When we test these things by hand in a plastic block, every continuously rotating instrument will have a propensity to go into the canal when it has a helical angle that is constant. For those of you who have experienced with the race instrument that has helical angles that switch from a positive to a neutral and then a negative, I'm not talking about rake angle, I'm talking about helical angle here, this instrument doesn't drive itself into the canal as much. But that's a moot point here. Anything that has a continuous similar helical angle will be threaded into the canal. Very low threading in force, the blue bars in the second path, as opposed to ProTaper Next that has very high and variable intensity of the file to be threaded into the canal. So objectively, we can know that this instrument will have smooth transitions and will behave very gently and very, for lack of a better word, easy in its handling characteristics. This is the torsional failure load. Stationary torsional load is measured at D3. And so, of course, the smaller instruments have less torque. This is measured in Newton centimeters, 0.3, similar to X1, 0.48, a little less than X2. Of course, the instrument is more delicate at that level, medium, even less. But remember that the torque settings are 1.5 Newton centimeters on the TruNatomy side and 3 Newton centimeters on the ProTaper Next side. So this instrument is sturdy enough. It doesn't break on you or anything like that, but it's very fatigue resistant and works very smoothly. People have asked, okay, what's the deal with the alloy? So this is, for those of you who are really keen on knowing this, these are the DSC curves. What they denote is that the instrument is pretty martensitic at room temperature and is going to be semi-austenitic at body temperature. This is good, because if you have an instrument that is purely martensitic at body temperature, it will plastically deform on you every time, right? So we need an instrument that is flexible, in other words, not operating in the austenitic elastic range, but operating somewhere in the martensitic transformational range, which is what this instrument does. And as I mentioned, it's somewhat martensitic, and then it falls back a little from about here, a little bit to here in its internal composition. If it was going to be purely martensitic, the therapeutic width, the deformation potential under work is only 2%, and then plastic deformation occurs. Here we have a much greater, up to 6% deformation range. And we don't want the instrument to plastically deform, yet we want the instrument to be as flexible as possible. Good. Final segment on this shaping question is, what kind of shapes are we generating? We generate very nice shapes. This is a data set out of Densplice lab, and I have similar data, of which I'm going to show you only one fraction. And this is the general models that we can use. We can use plastic blocks. This is out of our lab on the left. And we can use 3D printed teeth. Here's micro CT. We haven't done this yet on a larger scale, just spot checking. But 3D printed teeth allows some interesting stuff to be tested. When you use a tooth that is done from an actual human tooth as a 3D model, you can really look realistically at variables such as remaining dentin thickness. This is what we did. This is a radiographic model. It's a little complicated, so bear with me for that moment. Teeth were embedded and positioned in the same way, and were root canal prepared and then filled with different techniques. Again, the comparison here was ProTaper Next and TruNatomy. And then we measured at the levels indicated, 1, 2, 3, 5 to 10, at these levels, we measured remaining dentin or remaining plastic thickness in this particular case with different instrumentation techniques. And we found, and this is a pretty busy slide as I mentioned, we found that there's a significant advantage in teeth that have simulated small or large access cavities, with a more pronounced advantage in the small access cavities, because the ProTaper Next instrument intended to straighten the canal even more under constrained circumstances. Good. So, just as a general design information, there's a semi-active tip for the glider, as I mentioned, passive guide tip for the others. The cross-section I mentioned is actually not concave, but convex. I'm sorry for that error here. Taper, regressive, strongly regressive. Only the first 2 or 3 millimeters have a larger taper. Then the taper falls back to almost a zero taper. It's so-called superflex alloy, as I said, and therefore it's a very flexible instrument that has a sufficient range in the superelastic transformation. In general, I'm all for evidence-based medicine, right, or dentistry. But on the other hand, I'm not so sure. How do we marry these things? What can we know? Do we know, for instance, at this stage, that using this instrument only will extend the life expectancy of a tooth, or the retention time of a tooth, by 5 years? No, we don't, because we don't have 5 years of experience, right? So we have to still look at it. But in theory, conceptually, we know that we're doing the right thing. I don't know if Terry Dolan had the chance to talk about the white paper that we published with the FDI earlier today. I think conceptually, as a group, we have the obligation to do better. And that may be in opiate prescription, and maybe in root canal treatment, maybe in diagnostics, any and all of these things. We have to do better. What we're doing right now is this, right? A tooth erupts in all its glory, age 6 or age 7, and everything is great, 100% structural integrity, but it's a downhill journey. Why? Because of us, right? We decide when to initiate treatment. A small restoration, big restoration, early replacement, late replacement, whatever. We do this. It's a downhill journey. And not only we endodontists, but also our restorative colleagues. And the downhill journey doesn't stop there. It actually may end here. This slope ends in the extraction of the tooth at some point of age. Could be 50 years of age, 30 years of age, depends on the patient. The patient is not independent of all of that. Obviously, patient behavior is part of this game, but we can modify that behavior just the same as we can modify behavior of a patient that comes in and asks for a narcotic prescription, right? Let me tell you a story to this. So while I was sitting at my desk in Brisbane, Australia, and was talking about things and so forth, I got an email from a Danish restorative dentist, Ove Peters, who was the chair of restorative and actually the dean at the school in Aarhus. And he said, you know, there's really a crux with dental education. I think we're doing it all wrong. Out of 100 dentists, we only need 10. All the others should do something different. Maybe dental nurses or therapists or something like that. I said, Ole, that's a bit radical, right? And then he said, okay, now I'll give you another one. Specialists, we should take away with the specialist. Specialists only serve to justify their own existence. I said, oh, now you're getting on my nerves a little bit, right? But he said, by the way, he says, by the way, dentists have never improved the oral health of a patient. Okay, that's really radical. And except for in Denmark. I said, okay, so how do you know? Because I tested it. And he has excellent data to show that this type of slope, this type of repair mechanistic approach is not good. So what we should do is we should pay attention to every step along the way as restorative dentists, as clinicians, as physicians of the mouth, and certainly as endodontists. So if we can stretch out this slope so that the extraction is delayed as much as possible, ideally never occurs, then we have done good service to the patient. Pretty radical, right? So a couple of things to consider going forward. What kind of obturation is really going to be the right thing? You know, we need to make some experiences, consider something, but clearly at the moment, a vertical compaction is what this is being used for, and carrier-based, and perhaps, people will do single cone obturation with this type of instrumentation. I cannot hold the hand for that. We need to think of irrigation. There will be people that will say, okay, the size 26 with all the tapers and everything is not sufficient. Therefore, we provide a larger size, and therefore it's our intent to provide for refinement and retreatment also a true shape option. The irrigation needle is different, so we've got to look exactly how this handles best. We have a prescriptive way of doing it, but we need to make experiences with that type of needle. The overall package will be enhanced as we go along. And right now, we have a complete system at launch, but we need to take a look at other adjuncts as we go. And I had a question the other day, well, how about posts, right? In the ideal world, we had retained enough structure so that we don't need a post. But there will be cases where a post will be needed, so I have to look at that. And as I mentioned, a true shape may be a good adjunct. So, as a parting thought, I'm keen on structurally and, for lack of a better word, philosophically thinking this through. We are caught up in a paradigm. We do this, right, somewhere here, and we walk, because there is some intervention, we walk here, and we arrive at a true clinical outcome in a straight line. We start with A, we end with B. But in reality, we only look at surrogate endpoints. We only look at surrogate endpoints, right? And I don't want to be touchy-feely or anything like that. Surrogate endpoints are good and helpful. Sending the patient home with the white line in the right spot is a good thing. It's not wrong, but it's only capturing a small bit. In reality, there's a black box, and we may arrive at the endpoint, the true clinical outcome, completely differently, maybe despite of all we have done. right? So what I tell my residents, I don't have any residents anymore because I stepped down as the program director this week, but what I tell the residents, don't mess it up. If we don't get it wrong, the likelihood is that we are achieving what we want to achieve. The likelihood is very high. Not necessarily because of exactly what we wanted to do. So let's finish this thought by not believing me, but believing Kish Gulabiwala's people in London. And so this is probably the best study that we have in terms of survival outcomes. Most studies are clear on the fact that root canal treated teeth are retained for many years. However, we have to consider the fact that probably 50% of all patients, our patients included, have apical periodontitis. Wherever you define that, is it the presence of a radiolucent area in a periapical film, or what it is, 50%, looking into even cross-sectional studies of now. So the reasons for extraction, as I indicated earlier, are the 80-20, 75-25%. And what she writes is this about the restorative reasons, Paula Eng. Among the many reasons cited for extraction of root canal treated teeth, the most common were large carious lesion or unrestorable tooth fracture, periodontitis, and last of all, endodontically related disease. This is verbatim out of their paper. The restorative factors, and if you don't take anything home, take home the fact that the maximum parafunctional biting force in the posterior mandible is 800 newtons. The restorative factor should ideally include the amount and distribution of remaining structure, the amount of distribution of occlusal loading on the tooth and the function, and the type of final restoration. I think this makes a living document out of the path to a restoratively driven path to endodontic excellence. TruNatomy as a product, I really think it addresses this gap. It supports the strategy. It's a great product. The challenge, why change? Everybody says, I'm doing this and I'm happy with it, and I'm sure rightfully so. The market is so different. I travel a lot, I see people abroad, very different. We've got to tailor the message, but we really have to have the message first. And the clinical solution as we have it is hopefully dentin preservation as a means to promote longevity. With this, I'll be happy to answer any and all of your questions, but for right now, I thank you very much for your kind attention.